Well, why don't we go ahead and get started? So I'd like to welcome, I think, someone who needs no introduction at all. I'm a Honkai, someone who I've known, I think, for probably going on 20 years since residency, actually, who has been a long-term member of our CFAR, still adjunct faculty at Vanderbilt, but now at the Harvard CFAR as well, where she's an infectious diseases and also HIV physician, but also extremely well known in the field as a leading health equity researcher. And that's covering domains of epidemiology, behavioral science, implementation science. As I said, she's an associate physician in medicine at Massachusetts General Hospital, but also associate director of the Biobehavioral and Community Science Core, as well as director of the Community Engaged Research Program for the Harvard University Center for AIDS Research. She has been a leader in research on deliverable, equitable healthcare, and has led a number of different studies, both in the United States and overseas, particularly in West Africa. Much of her recent work has focused on innovative mHealth supported and community-based intervention strategies in the US and West Africa, where she leads multidisciplinary teams in these areas. And her work has spanned from developing unique mobile health-based interventions to promote medication adherence for youth living with HIV by harnessing the power of social norms, and that was her Piranija project, to also improving mental health outcomes for youth living with HIV by tapping into the power of storytelling, which was her Change My Story project. And then most recently, something that we've been particularly excited about in our CFAR and done our best to support is her phenomenal partnership with Barbers in Middle Tennessee to reduce HIV stigma for Black men in the region. And that is the Cutting Out Stigma project, which I think is still ongoing. You led a really phenomenal startup workshop here at Vanderbilt not too long ago. So she's worked on global and local programs to improve access to HIV prevention and treatment, as well as had a major role in the response to COVID-19. And so I want to thank you for coming to present today. This is our CFAR seminar series, and I'll turn it over to you.
Wonderful. So it's really a pleasure to be back with you virtually this afternoon. And this is the title of the talk that I'll be sharing today, Leveraging Academic, Public Health, and Community Partnerships to Advance HIV Equity in Tennessee. So this is the outline that I'll follow today. I'll tell you a little bit about my personal background, some overview comments about partnerships and community engagement. And then I'm going to use 3 examples from my own research or research that I've been involved with as a collaborator to talk about how we can use this framework of partnerships with community to enhance what we do, to enhance what we know, and to enhance our voice as researchers. So this Venn diagram highlights some of the touch points of my research program. I am really committed to improving the care of minoritized individuals who are living with HIV or at risk for HIV. And as John Curta mentioned just a few moments ago, a lot of that work has focused on adolescents and young adults. But I also come to this work as an African-American woman, as a product of Nigerian parents, raised in America, so someone who is very much in the diaspora. So for me, and I think for many people who come to this work specifically in HIV and in health equity, this work is definitely my professional work, but it's also very deeply personal. And that is why health equity is really at the core of what I do as a researcher. So I want to take you back with me first, more than 25 years ago at this point, when I was an undergraduate at Harvard University, and I had the great pleasure to partner with my father and his colleagues in building an immunization program in my grandmother's village. Here pictured is my family house, my grandfather's house, where the immunization program for children 5 years and under was situated. And this experience, I didn't realize it at the time, was teaching me really foundational principles about engagement. So in order for this program to work, there was engagement with mothers of children under 5, with traditional rulers, with the elders in the community, with local government, with local clinicians. And as a result, this program successfully provided immunizations to children under 5 for 16 years until the government systems and infrastructures were really capacitated to take it over. And this work really forms the basis of the way I approach research today. So now I'll move to another infectious disease that we all know and are well acquainted with and committed to. And this statement probably is not a surprise to anybody who's on this call that we have the tools that we need to end the HIV epidemic in the United States. And it's also not a surprise for me to share these statistics. We know that the HIV response has been plagued by racial inequities in the United States. Black Americans face the most severe burden of HIV disease. They make up 14% of the US population, but 38% of new HIV infections. The lifetime HIV risk, according to most recent estimates among Black men, is 1 in 22. But when we look at the lifetime HIV risk among Black MSM in the United States, it's 1 in 3, which is still quite striking. And Black women are not left out of this story. Among all new HIV infections among women in the United States, 54% are among Black women. And when we start to think of other intersecting identities, we know that youth remain a priority population for HIV, both domestically and globally. But in the US, 13 to 24-year-olds make up nearly 1/4 of all new HIV infections. And more than half of these youth are Black youth. Some really nice modeling data from my colleagues, Dr. Rich and Dr. Heil at MGH, have really emphasized that if we continue with status quo approaches to address the public health priorities for HIV, we'll only really worsen racial inequities by making our advances available to the same communities and continuing to marginalize the same communities. So from my perspective, then, is really tackling these inequities is critical to us getting to our goal of ending the HIV epidemic in the United States. So moving to Tennessee, I will fly through this because we don't need this introduction here, but there are about 20,000 people living with HIV in the state of Tennessee. Much of the infection is focused in 4 out of 95 counties, and continuum of care outcomes continue to be below national targets. Shelby County and Memphis has the second highest HIV incidence of metropolitan areas in the United States. And just like on the national front, Black individuals continue to be disproportionately affected. So when I first joined the faculty at Vanderbilt several years ago, I had the fortune of getting a developmental core award from the CFAR. And the infrastructure of the CFAR allowed me to work directly with the Tennessee Department of Health, which was wonderful. At the time, the HIV program directed by Dr. Carolyn Wester, and I was able to talk with her about the priorities for TDH. And at that point, TDH had invested a tremendous amount of resources in trying to improve linkage to care, because this is an indice where Tennessee was really trailing in the United States. And the question was, how have these efforts helped? And in order to do that, we partnered and looked at this data over a period of 5 years. It's quite old at this point, but you can see from the blue lines that linkage to care really had not improved over that time. But because of the relationship and infrastructure that developed, we were able to ask the next question. And the next question was, well, who is really not linking to care? So we did this analysis where we looked intersectionally at age, transmission risk factor, and race ethnicity. On the y-axis here, you see probability of linkage to care, and on the x-axis is age. And so we were able to see here, just looking at the male data, that in red, the non-Hispanic Black individuals have the lowest probability, and the younger age groups have the lowest probability of linking to care. So overall, it was really young Black men in general and young Black men identifying as heterosexual who had the lowest probability of linkage to care. And that led us to ask, how do we find Black men with HIV who are hidden from care? And so I want to step back and look at this framework that is commonly used in implementation research. So we have a number of evidence-based interventions for HIV. We have excellent antiretroviral therapy, we have pre-exposure prophylaxis, we have peer navigation, point-of-care testing, so many evidence-based interventions. And then we have this public health goal of ending the HIV epidemic. But the question is, how do we bridge that gap between what we know and what we do? As I mentioned, implementation research is a really powerful tool to help to bridge this gap. But I want to emphasize throughout this talk how the partnerships that are really leveraged through community engagement can really help us to bridge this gap as well. So as I mentioned, the Tennessee CFAR is really unique because we have this infrastructure that brings together public health partners, academic partners in Vanderbilt and Meharry, and community partners in Nashville Care. Only 5 out of the 19 CFARs have a public health partner that is really embedded into their CFAR in this way. And these partnerships are quite unique. I want to step back for a second and just talk about what is community engaged research, because community engaged community can look like the health department, community can look like Nashville Cares, community can look like many things. But community engaged research, and this is a definition from the Kellogg Foundation that I like, is a collaborative approach to research that equitably involves all partners in the research process, recognizes the unique strengths that each brings, begins with a topic of importance to the community, something that we sometimes struggle with as researchers, and combines knowledge with action for social change to improve community health and eliminate disparities. So why did we incorporate these partnerships? As you could see from the example that I gave earlier, we can bring real world relevance and public health impact. So going to the health department to say, what are the priorities that the health department needs to meet is a really powerful place to start, and going to communities to ask the same questions. It can help us to increase community trust. We can have access to really robust data sources that would not otherwise be available, like the surveillance data set for all people living with HIV in the state of Tennessee. This helps us to conduct better science and to conduct science that's more applicable to the communities we're interested in. And it helps us to create a pathway to implementation and sustainability. So not just a study and intervention for the sake of showing that something can work, but doing it while we're studying how we can implement and sustain that intervention as well. And for all of us that are partially motivated, at least by money, funders are increasingly requiring us to do this. So let me step back and say what we did next with the question that I posed earlier: how do we find Black men with HIV who are hidden from care? So because of this relationship with the Tennessee Health Department and the fact that we were committed to looking at this question further, they said, why don't you go and talk to StreetWorks? StreetWorks has been working in the Black community in Nashville for years, and they've been working with Black barbers. Barbershop is a place that Black men go. And so that's exactly what we did. And we established an academic community partnership with StreetWorks and Vanderbilt. And then we recruited a cohort of barbers in Middle Tennessee. And we shared with them the data that I just shared with you. We talked about what the public health goals are, and we asked them, how can we attack this problem? So why barbers, you ask? And so those of us who are clinicians or go to a doctor, we see our patients a handful of times a year if we're lucky. But if we're talking about barbers, Black barbers, they may see their patrons between 1 and 4 times a month. So many, many more touch points for engagement, which is critical. And then when we talked to this group of barbers that we formed a partnership with early on, and we're sharing this data, they said to us, Black men don't like to go to the doctor a lot. That's what Black men do. We don't go until we're damn near dead. And that's exactly what our data told us. So if we were going to think about doing something that was situated from within the healthcare system, it probably wouldn't be successful. But the barbers also told us, we're like bartenders, like the doctor before the doctor, and like psychiatrists, because people come to us and they feel like we're trusted. So here we're hearing that the barbershops are trusted spaces. The barbers are trusted messengers within the community. So maybe we can use this infrastructure as an avenue for intervention. Another really important thing that we did was listen. So we had these initial conversations with barbers, and we were talking to them about the goal of linkage to care, as I mentioned. But what we were hearing a lot about was stigma. One barber in these conversations said, I'd rather get shot than say I got AIDS. Another one said, so it's one of those things that honestly, I feel as though it would need to be recategorized, like repainted, to come up with a different name for something instead of AIDS. You have to rename it. I don't want to hear AIDS. So we were hearing about stigma, and we took those conversations seriously and said, okay, let's pivot and let's think about how we can address stigma. So that's exactly what we did. So we worked together to develop this project, Cutting Out Stigma, a barbershop-based strategy to reduce stigma towards Black men living with HIV in Tennessee. And this is a product of our academic community partnership. And the objectives of this study are three. They're listed here. The first was to develop a multimedia stigma reduction campaign that includes print media to spark conversation. So that would be up in the barbershops along with billboards in the community and social media to be posted by barbers with the idea that we would blanket the community with a different type of messaging that the barbers could help to spark this conversation and educate the community in a different way. So we would then recruit and train a cohort of Black barbers in Tennessee to become these barbershop-based men's health ambassadors. And then we would assess the implementation outcomes of this approach using implementation outcomes and measuring preliminary effectiveness to address HIV stigma in Memphis and in Nashville. So if you've never been in a Black barbershop, I want to show you a little bit, a very short clip of one of the barbershops the barbers we're collaborating with to just envision how this process might unfold.
What is HIV, and that's his partner. What's HIV for y'all?
I ain't gonna say that we don't think about it, and you know what I'm saying? It's just like, I don't know, they just, new generation, I use condoms.
You a condom user?
Yeah, I use condoms. I
What
mean,
about
like,
you got kids.
Hey, you gotta put that on a t-shirt. I'm a condom
you know what I'm
user.
saying? I'm a condom user, because I don't want no other kid.
I heard that.
I got one, that's all I need.
But it's only about kids. You don't think about HIV?
No,
Is that why
I
you
mean-
wearing the condom? No, I'm just saying, you just said because you don't want kids. I
do
definitely
think-
feel you
I
there.
do.
Just
I
said
do.
it. That's what they thinking. That's
I
what they
think
looking
about
for.
kids more than I think about
I ain't
HIV.
studying the disease.
Right.
I don't want
But-
no kids.
But at the same time,
They don't even know about crabs good. You know what I'm saying?
We are really excited to launch Cutting Out Stigma and prepare to build on its success to target specific continuum of care outcomes for Black men in our region, especially linkage and engagement in care, along with other important health needs. Thanks for listening.
What is it?
So as I mentioned before, we've taken a shared leadership model approach for this partnership, where we have StreetWorks on this grant as co-PIs. We have Nate and Steve pictured here, who we've affectionately called our barber investigators on the study team. We compensate our community partners as content experts, and we take real pains to acknowledge the mutual contribution and benefit of voice of all the partners on the team. And everyone on this team recognizes that this is not an easy process. It takes time, it takes patience, but I think it leads to remarkable potential for impact. So as I mentioned earlier, the first objective of this grant is to develop a multimedia stigma reduction campaign. And this has been informed by qualitative work led by Jessica Perkins, who has now joined me to lead this grant. And this qualitative data has led to three emerging themes. The first one around HIV itself. And we've heard from the community that on the one hand, is HIV even here anymore? Is it relevant? Didn't it go away with Magic Johnson? And on the other hand, is this entrenched stigma that I shared some quotes with you about earlier. Another theme is around the conversations in the barbershop, where we hear, well, we talk about everything in the barbershop, and we talk about sex, but we don't talk about sexual health, and we don't talk about STIs, and we certainly do not talk about HIV. We heard from barbers that they would need to maintain masculinity in the context of these conversations. And we heard how important language is. I've shared with you for several minutes about racial disparities about HIV, and we heard from the barbers that we need to frame our conversations positively, that we don't need to hear anything more about negativity in the Black community. And so we've taken that to heart as well. We heard also about media preferences, how on the one hand, we need to capture attention discreetly. On the other hand, we need to make sure the media can spark conversation and really lean into the multimedia options available to help them share this message. And I'll show you how we've started to do some of that. We recruited barbers, and I'll share some more details, to really participate in an intensive day-long training because in order for them to serve as these ambassadors, they have to be well equipped to do so. And we thank the SEATC for their help in organizing the curriculum and the training. I want to point out also that in blue, the agenda items in blue for the curriculum were really brought to our attention and integrated by our community partners. So instead of focusing only a presentation on HIV by itself, it really needed to be presented within the context of men's sexual health. They wanted to learn about what it's like to live with HIV today from people who are living with HIV, and they wanted us to have a session on mental health. And even though this is an HIV training, we really needed to respect that mental health was on the minds of people, and we needed to really incorporate that. Also to talk about communication strategies. And importantly, we integrated a community resource fair into the training as well. So after this intensive 10-hour-long training, the barbers stuck around to participate in a resource fair where we had vendors not only who were focused on HIV prevention and treatment resources in the community, but resources like, how do I sign up for health insurance? What's available to me for mental health resources? What if I need a financial planner or someone to help me with wealth building? What if I need legal resources? So recognizing that the barbers and their patrons would be coming to these conversations as whole people and might need resources well beyond what was related to HIV. So this is an image of the Men's Health Ambassador training that was held at the Strategy and Innovation Center. It was a wonderful event. This is the one in Nashville. We also had one in Memphis. But I want to also highlight the intentionality that we had to bring to this planning, because we had a room full of mostly Black barbers. We had Nate and Steve pictured here, who are our barber investigators who were part of the presenting team, but we also had experts, content experts who were all African American. And that was really important because we needed experts in the fields who could relate to this population and communicate this information in the most compelling ways possible. So some data. So we recruited and trained 67 barbers in Nashville and Memphis. Their median age was 40, 94% identified as Black or African American, and 67% had education higher than high school. We were able to show an increase in their HIV knowledge scores from before to after training, but noting that there's still room to improve. And then we had some other pre-implementation outcomes. We could see here that their enthusiasm was quite high to participate in the intervention, 92 out of 100. We also assessed readiness, acceptability, appropriateness, and feasibility using validated implementation scales on a score of 1 to 5. So those were all quite high, and 4.63 and above. We conducted in-depth interviews with a portion of the barbers who completed the training, and this was really helpful. It both gave us really rich positive feedback about how we could better prepare them to be involved in the intervention, but it also just told us that we were on the right track. And I want to share these two quotes. One barber said, "I feel really prepared because it's already came naturally to me. I talk to my clients about everything, their health, their hair health, so it's just involving sexual health. So it's easy to integrate this into my regular conversations." And another barber said, "I feel good about that. Just by saying something could make the smallest change in the statistics over the years. So, I mean, I'm excited to share. It helps me feel good, like I'm fulfilling my purpose." This was really powerful for me, kind of thinking about the idea of transforming these negative messages about racial disparities and inequities to ways in which this community of mostly Black men could fulfill purpose in a different way. So moving on to the multimedia campaign, thinking again about intentionality, this campaign was developed by Mojo Marketing PR, which is a Black-owned media firm based in Nashville. So they've developed a lot of materials for us. This includes this poster that is up in all of our barbershops that are participating in the intervention, swag materials that the barbers will get. This is an example of the billboards that'll go up in the coming weeks in Nashville and in Memphis. And this is an example of the social media posts. So the participating barbers have a social media content calendar. The ones involved in the intervention are posting weekly for the intervention. And this is an example of one of the earlier posts that's focused more broadly on healthy relationships. So it says, chopping it up in the barbershop is good for both the mind and soul. It's important that we foster healthy relationships with Black men, and let's look out for each other's well-being. Let's keep these convos going and continue to cut the stigma. So we are trying to move the needle on stigma. So wanted to share some of our baseline data on stigma that we obtained from the barbers who participated in the training and patrons in some of their barber shops. So we used a stigma scale that goes on a rating from 1 to 4, with 4 being high stigma. And I'll highlight here, if we look at overall community stigma is higher than total stigma. So community stigma is the person who's filling out the survey, their perception of stigma in the community versus their perception of their own levels of stigma. And then barber stigma was higher than patron stigma. And then when we look at differences by location, we see that patrons in Memphis had a higher stigma scores than patrons in Nashville, though we had far fewer complete those in Memphis. So that data were really interesting, and it leans into some of the expertise of Dr. Jessica Perkins, who I mentioned before, who is leading this grant with me. And her research on social norms really emphasizes how adults who misperceive positive local norms are less likely to engage in prevention behaviors and more likely to engage in transmission risk behaviors. So quite frankly, we weren't expecting to see this difference with barbers rating community stigma higher than their patrons, but it leads us to ask, how do these misperceptions about community stigma impact prevention or treatment attitudes and behaviors? And what are the messaging and education strategies that we can use to address these misperceptions? So these are some of the things we'll have to think about as we move on in the pilot and move on to further studying. So we are about a little bit over 2 months into this pilot now. We've had a tremendous time rolling this out across Memphis and Nashville. And our next steps are to complete the pilot, really manualize this intervention, and then move on to conducting a multi-site, multi-city implementation and effectiveness trial where we can really measure beyond implementation outcomes to see how effective this approach is. And we're really excited about our next steps. So now I want to move on to our second example and looking at how this framework can enhance what we do. And this example is really highlighting a collaborative model of community engaged research in contrast to the shared leadership model that I just shared. So now we're talking about mobility. And by mobility, I'm talking about where you live, where you sleep, where you lay your head. And the US population experiences regular mobility. And mobility has been associated with increased risk of HIV infection or acquisition, and likely impacts the entire rest of the HIV care continuum, but there's really not a lot of research focused on this in the United States. This is a figure that really highlights that there are a number of factors that impact an individual's mobility. Push and pull factors that may be related to healthcare access, employment, social connections, and these can really affect at every level that we measure across the HIV care continuum. You know, as a clinician, when I was seeing patients at Vanderbilt, I would see this quite commonly, and it was often my young patients who would kind of disappear from clinic, and then they'd come back many months later, oftentimes having been out of medicine or having some care need that they needed to meet. And many times they were growing across state and not realizing that they wouldn't have access to their Ryan White services or their insurance services when they left the state. So clinically, it was a really relevant question as well. And it made us ask, can our evidence-based interventions, the ones that we currently have and promote, can they really meet the needs of mobile populations? So we partnered, Kate Kloss and I partnered with a bunch of wonderful people across Tennessee at the Medical Center, at the Department of Health, at the Vanderbilt Institute for Spatial Research, with support, again, from the Tennessee CFAR to look at this question. So our objectives were to determine the prevalence and patterns of mobility among people living with HIV in Tennessee, and then to assess what the impact of within-state mobility was on continuum of care outcomes. So how did we approach this? So we looked at all people living with HIV in the state and looked at, so in 1 year, looking at the number of moves and the total distance moved, and whether that mobility was associated with care continuum outcomes in the following year. And the definitions we used for those outcomes are in the box on the bottom. So again, how did we do this? So we looked at everyone in the cohort living with HIV in the state, And we looked at addresses from the Accurate database. This is a LexisNexis database, the same database that the police use to find you. So it updates contact information, addresses, etc. And the Tennessee Health Department, their HIV surveillance data is merged with this database to update addresses. But of course, we couldn't have the actual addresses of people living with HIV across the state. So we de-identified those to a census tract, and that is a subdivision of a county, so much smaller than a county. So we were able with that to see if people moved from one census tract to another and what the patterns of mobility looked like using line density tools, which I'll show you in a moment. So first, just taking a look at this picture, which is worth 1,000 words. So again, this is people who were living with HIV in the state. They were either diagnosed with HIV in the state or living with HIV in the state according to their medical records. But if we could see where they are living and moving, it's all across the United States. We also were able to see that nearly 1 in 4 people with HIV in Tennessee experienced mobility. And this is about 4 times that of the general population. When we drill down to the southeast using this line density tool, where the darker shades represent more frequent paths of movement, we see there's a lot of movement, not surprisingly, between Memphis and Nashville, but also to other cities, Atlanta, Chattanooga, Knoxville, and Johnson City. We looked at who were the most mobile populations in Tennessee, and this included young persons, non-Hispanic Black individuals, and then with regard to transmission risk group, it was people who injected drugs and individuals who had male-to-male sex. And you can see the adjusted risk ratios in bold there for these populations. Next, we looked at whether this mobility was associated with continuum of care outcomes. And I'm just highlighting here distance moved, but we saw the same types of relationships with number of moves. So here we're looking at a forest plot that shows adjusted risk ratio and miles moved. So we can see that compared to no miles moved, individuals who moved between 50 and 1,000 miles had anywhere between a 6% and a 47% reduction in their risk of being retained in care. And then when we looked at loss to follow-up, again, looking at people who did not move any miles to those who moved 1,000 miles, there was anywhere between a 14% and a 2.5-fold increased risk of loss to follow-up. These were analyses that were adjusted for all of the variables noted here. So it was a really significant dose-response relationship between the distance moved and these engagement outcomes. Notably, there was no association with viral suppression, and I think that's some artifact of our analysis and missing viral loads from the data set. We were also able to really describe mobility patterns that differed by important HIV populations. So you can see here, for example, people who inject drugs show a very chaotic and heterogeneous pattern of mobility compared to individuals who identified male-to-male sex as their transmission risk factor, had a much more homogeneous mobility pattern that looked more like the map I showed you earlier. And we were really interested to understand what was driving these different patterns of mobility. So as part of our partnership with the Tennessee Health Department, we were able to get these perspectives from case managers and surveillance coordinators across the state who were employed by Tennessee Department of Health. And they identified some important structural factors that they felt were driving this mobility. And this included the need to access healthcare services, transportation needs, housing support, and stigma. So wanting to be in communities with less stigma. And I'll read this quote that said, in some counties, people didn't even want to live. We had a lady that no one could know she was HIV positive because her dogs were targeted. You know, it's backwards here with stigma. So that was from a case manager working in a more rural area in Tennessee. So our next steps from this work are really to test this conceptual framework that we've developed about structural factors like racism and stigma and the need for healthcare access and housing, and how those impact mobility and HIV care outcomes. We want to be able to describe mobility phenotypes of highly mobile people living with HIV and those who really are at greater risk for having poor care outcomes. because I don't think the structures that we have now are developed to meet their needs. And that's our goal, to figure out multi-level interventions that can better meet the needs of these individuals. So we were recently funded by the NIH to do this, and we're really excited about that. But our collaborations with the community include the Tennessee Department of Health, but they go beyond that. So before we even put in the NIH grant, we went back to the Meharry Vanderbilt Community Engagement Studio team to help us convene a group of young people living with HIV to talk about this research, to ask them if it was relevant, to ask them if our approach to these questions made sense to them. And I want to highlight a few things we learned from that studio model. One is that the research very much was relevant. One participant said, I can't count on two hands how many times I've moved, at least 10 times. Another one said, I'm excited about the outcome. I think this could be really impactful, especially here in the South. So in this grant, we are planning to follow prospectively a cohort of young people living with HIV and monitor their mobility using their mobile phone devices. And so when we presented this idea, participants said to us, I think it would be awesome to see the individuals' trackings, informations on places to go, areas traveled, ping locations. It would be really cool to see all of this information. So this is telling us, this is something that should really be a part of our protocol, and it is. Another person said there's still a lot of laws and policies in place that are targeting people with HIV. So I would want to make sure that the statement that the information would only be shared with people in the study. So we have to make sure that we ensure for participants how we're keeping their information private. Another person said a lot of times we're all alone in our journey and have troubles understanding and getting to know others. So having opportunities for support group, meeting on Zoom, and meet in person to talk and check would be good. This comment really stuck with me because we were talking about enrolling a prospective cohort of 300 young people living with HIV across the state, and thinking about mobility and thinking about care needs in that regard. And this person said to us, you're creating a community of people, and we actually need to find each other. We need each other. So how can your study help us do that? And that was a really powerful suggestion that came to our team through this community engagement studio. So that's example 2, thinking about mobility. And I'm going to spend the last very brief part of this talk on research as advocacy. So again, we have our evidence-based interventions. We have our clear public health goal. We have the bridge that implementation research can help us with and community engaged research can help us with. But sometimes our foundation is completely shaken. And that's when I think we can turn to research as advocacy. And we can think about times like now where we have a political election, a political climate that may destabilize the type of work we do, the type of research that we do, the type of funding to support it, or other really critical parts of our identities and our priorities. And I want to use this example to highlight this approach of research as advocacy. So taking us back to January of 2023, you may recall that TDH announced that it would not accept 2 CDC grants supporting HIV prevention efforts for the state. And at the time, the state had shared that it had determined it was in the best interest of Tennesseans for the state to assume and direct these financial and managerial responsibilities. So there was a tremendous amount of outrage over the next couple of months. Ultimately, in May of 2023, the CDC announced it would bypass the Department of Health and directly fund CBOs. And then later the state announced that it was also directly going to award CBOs funds. So there was a lot of turmoil, as you can imagine, during this time. Also, the state announced that it would focus its efforts on new priority populations, and these included first responders, victims of sexual trafficking, and pregnant women and children. So as I mentioned, there was a tremendous amount of local and national advocacy and outrage, many from the folks on this call, from community-based organizations, from clinicians, from researchers, from national partners, from disease-specific organizations. And it really showed advocacy at its best. I think I will certainly share that it was a really emotionally trying time. It was really difficult to figure out how to navigate this period, how to be effective, both as a clinician and as a researcher and just as a community member. And so I'm really grateful for the leadership in the HIV Medicine Association, who was listening to all of these conversations and then brought together this dynamic group of individuals to think about how we could use research in the moment. So this analysis was led by Drs. Ethan Bory and Ann Nealon, and I thank them for sharing these slides with us. So the objective of this analysis was to determine the 10-year clinical and economic consequences of HIV prevention resource allocation in Tennessee. And I would say even further, the goal of this was to say, how can we use our voice as researchers to step into this policy debate and make a clear stance that was backed by data? So the analytic overview for this approach, they used the CPAC model as a widely cited microsimulation model of HIV disease that models cohorts of people who do not have HIV infection or have undiagnosed infection and present into care either through routine screening or through symptomatic disease, and then follows these individuals through diagnosis, treatment. Some individuals develop morbidity and mortality through predefined probabilities. So for this analysis, we modeled Tennesseans who are at risk for HIV and living with undiagnosed HIV. And the two strategies modeled were the current strategy that utilized the current allocation or the older allocation of CDC-funded prevention activities, condoms, PrEP, HIV testing, and then the reallocation strategy that was focused on the Tennessee predetermined populations. And the outcomes included 10-year HIV transmissions, death, and life years lost. So as I mentioned, there were two priority populations, but just to emphasize here, the CDC priority populations, MSM, heterosexual Black women, and transgender women, really comprise the vast majority of those individuals who are living with HIV in Tennessee. And we know this, but just to see this is quite striking in an image. Tennessee priority populations represented 1% or less of all individuals living with HIV in the state. So what did this modeling data tell us? So we found that there would be 166 additional HIV transmissions in the CDC priority populations and 0 HIV transmissions prevented in the Tennessee priority populations. Additionally, there would be 190 additional deaths and 843 life years lost. We felt it was really important to make an economic argument as well. And so we included in this analysis the cost for averting a death for a person living with HIV. And under this new funding allocation strategy, that cost would increase by 1,300%. So where are we now in this debate? I think through a lot of advocacy and through data-backed including the analysis that I just shared with you, we're at a time where the CDC has announced renewal of this direct funding, and the state has also announced renewal of this funding. The difference being that the funding is now on a year-to-year basis rather than a 5-year cycle. And so there's a lot of still fear and uncertainty about what that means for the longevity of HIV prevention programming. As you may have heard, there have been reports of increased HIV and STI cases in Memphis, some opining whether this is related to this really chaotic year prior that was really focused on prevention needs in the state and in Memphis. I also want to highlight that Dr. Pettit and Dr. McKay are doing additional work in this space to really highlight, use other modeling techniques to highlight the impact of these decisions and to further use qualitative methods to understand the economic and social impact of these policy changes on people across Tennessee. So in conclusion, I want to highlight how community-engaged research and informed partnerships are really essential to drive health equity. These partnerships can inform what we know, what we do, and how we lend voice to the public health priorities of now. I think that research is a tool that we can use to unapologetically put equity at the center of our activities, to resist and disrupt the status quo, and to challenge ourselves to think creatively about how to bridge the gap. I also want to lead with some questions for our CFARs, these unique mechanisms across the country, and think about how can our CFARs enable underrepresented research faculty to address the urgent health needs of our communities in the ways that we are uniquely poised to do. How can our CFARs leverage institutional infrastructure to foster trusting community relationships that can be ready to respond when funding opportunities come our way? And how can our CFARs remove the many institutional barriers to engaging minoritized and marginalized communities as partners and collaborators in research? And these are just a few questions of many, but I want to leave that with the group. And thank you so much for your attention. I'd like to acknowledge the many partners along the way. Thank you.